First of all, just an announcement. Would you please take care of this earpiece? Don't throw it in the earth, because we have 3 broken ones, and it is very difficult for the technical points. Please. It is an unusual pleasure and honor to have at this moment 2 prestigious guests, Professor Nagy and Professor Nagy. Professor Nagy, I leave Professor Samir to introduce him, but I want just to tell you something about him. We learned very much from Professor Nagy, from his education capacity, from his sincerity, from his loyalty. He is very keen. And he's working, so although he is not, he has his private clinic, but he's working within the Faculty of Medicine at the Mansoura University Hospital from 8 o'clock in the morning to 8 p.m. and then go to his clinic, private clinic, while he is very exhausted. This is because he is very keen to do his best. He is currently the director of Mansoura Manchester medical program that you visited today, and he's a professor of internal medicine and nephrology. He's the chief of nephrology service at Mansoura University Hospital. I myself learned a lot from Professor Nagy, and I leave Dr. Samir just to introduce him.
After your introduction, Dr. Nagy is one of the best nephrologists here. And he is a very old friend to us since long time. Professor Nagy is the head of the nephrology department of Mansoura Faculty of Medicine, and he will present a very important talk about Dialysate in focus.
Thank you very much, Dr. Samir.
But you are not very old. You and Dr. Samir are still not very old. Yeah, still.
Thank you for your nice words that I don't deserve all of it. Welcome Gada, welcome Samir, and
طبعا اللي عندهم جمله تبقى تشيل كده هو خايف
about dialysate, and I'm gonna do some focus on this dialysate. Actually, the topic is large, and I cannot cover all of it in one small lecture like that. So I'll concentrate on some important issues. First of all, let us review what happens to a patient with uremia, chronic kidney disease, or acute disease. There are a lot of molecules, solutes, and substances that might accumulate in his blood and in his body due to lack of its excretion by the non-functioning or the deficiently functioning kidneys. And now we are glad that we cannot get rid of these molecules because the kidneys are the most important and main route of elimination of most of the solutes that we are come across during our metabolism and our digestion, our diets. So the body now is full of very wrong concentration of some molecules and wrong amounts. We need to get rid of it, and the kidney is not working. So before dialysis, this was served. Any uremic, acute or chronic, would die because of lack of removal of this molecule. So this molecule is just like dirt. So if you need to get it clean, what you do for your clothes, you wash it. So we have to wash it. This is a nice idea. Then we go to wash. But how can we wash our body? It's how we wash our clothes. We can use just water and soap, or we can can we apply this to our body? Let's see. Yeah, this smart young boy is trying to wash himself like that. And if we use water, what is common here is we use a lot of water to wash dirt. And if this is the dirty uremic, look, can we wash it to be nice like that? Can we improve this look and this ugly nails to this nice, clean boy by washing with water? The skin cannot work like that because the skin is not that permeable to internal solutes. So we have to look at the blood. This man, Thomas Brown, is honored as the father of dialysis when he started to describe the diffusion of molecules across a semi-permeable membrane, though this notion was made use of by dialyzing blood. Actually, we cannot mix blood with water because water is very toxic, and we cannot use soap in our blood to wash the dirt. And this soap and water doesn't clean the solute that we want to clean. So we have to look for something else. And this something else has been brought about by the notion of Brown, and this was in the late 19th century. And this was the early dialysis filter machine, which was very troublesome. And now we move to a new one, which is compact and nice and can patients a lot. And we make use of a semi-permeable membrane between a blood compartment and dialysate compartment. So if we can compose this dialysate to be what we need it to be to clean the blood, then we can manage doing that. And this is the principle which is called diffusion. This means that the substance diffused according to concentration gradient between the blood and dialysate. So those with high concentration gradient in the dialysate would diffuse to the blood, and vice versa. The high concentration in the blood would diffuse to the dialysate. So we compose the dialysate carefully so as it does not contain any uremic toxin, and it's quite easy. But it should contain appropriate osmoles to be equivalent to the blood osmolality, and appropriate electrolytes and buffer so as not to deplete the blood from essential elements. So we have to compose it very cautiously. Diffusion is the main route of dialysis per se. If we speak about dialysis, then it is diffusion. But other modalities are there also, like ultrafiltration. When we exert pressure across the membrane, and this pressure causes water with convection, some electrolytes, and some solutes to pass through. We make use of osmosis and convection. And this is the structure of the dialyzer here, when the blood passes from one end and exits from the other end, and the dialysate passes it all around. Across this membrane, diffusion occurs, and we get rid of the toxins and we wash the blood. So we make use of water and some dissolved solute to wash our blood, like this young boy was washing his face to make it cleaner. And the panel on the left-hand side demonstrates some hemodialysis when dialysates gets in from here and out from there, and we compose this by certain methods to make the composition ideal. And the blood goes from one end to the other end, and the dialysate That is the blood all around. This is another technique called hemodiafiltration when the filter is more porous. This is hemofiltration, hemofiltration. When there is no dialysate at all here and the filter is porous, so we get rid of the toxins by convection without dialysis or without dialysate. But this hemodiafiltration makes use of both the porous filter, a lot of convection, and also some dialysis going on. So we make use of dialysate and make use of a porous filter that gives rid of the Western products. Now let us focus on the dialysate circuit. The water comes from the municipal water and now passes to a water treatment system in a station usually nearby the dialysis unit. And in this, a lot of steps, I think Professor Samir has covered it. You covered Samir in your
Water treatment.
Yeah, the water treatment. But after that, this treated water goes to the machine. Inside the machine starts by heating. Then there is some gas forming. Then we do deaeration or degassing. Then mixing the water with a concentrate dialysate. And then after that, we do some sort of monitoring and measurement to make sure that this water has been mixed up to a good technique. This is how the water is treated, and this is, I think, Professor Samir has covered that. The substance and maximum allowed concentration in the water going to the dialysis machine. And this is the microbial content. And if the purification of water is not complete and there are some abnormal amounts of minerals or metals, there will be a lot of toxicity, like you see here. Now, this water is mixed with some concentrate to make the final dialysate. And we aim that the dialysate contain appropriate concentration of essential electrolytes and essential elements. Otherwise, these essential electrolytes and elements will diffuse out from the blood to the dialysate and the body will become depleted of that. So it has to contain sodium in a concentration that is appropriate to the body function, like 135, 145. Potassium, something from 0 to 4, because the body of the uremic patient is usually loaded with a lot of potassium. So we have to make the potassium lower in the dialysate to get rid of the maximum amount possible of potassium. Chloride, like the body chloride, 102 to 106 millimole per liter. Bicarbonate or bicarbonate and acetate from 30 to 40. Calcium from 0 to 3.5 milliequivalent. Magnesium from 0.5 to 1 milliequivalent. Dextrose up to 11 millimole per liter, and the pH of the dialysate usually is around 7.2. So this is the targeted composition that we want the dialysate to contain. It should not contain any uremic toxin, should not contain urea, should not contain creatinine, and should contain appropriate concentration of the essential elements that we did not want our body to be depleted of during dialysis. Now, after the water preparation, there is a proportion system. The proportion system makes sure that there is appropriate proportion between the purified and treated water and the concentrate. And there are many types of proportioning systems, like the balancing chamber and the ultrafiltration controller. And then after that, the machine should make sure that this composition of the dialysate is appropriate. Otherwise, if there is any faulty composition, it might be hazardous to the patient. The patient might suffer. So this monitor includes conductivity monitor that measures the conductivity. So make sure that the concentration of the electrolytes are as needed. Temperature monitor to see if the temperature of the dialysate is high or low, that is not desired. And then we measure for blood leak by a blood leak detector to make sure that there is no blood leaking from the filter to dialysate. And some machines are endorsed by pH sensors, and there are also some blood circuit monitors like arterial and venous pressure monitors and air detectors. Now, during dialysis, we make use of the hydrostatic pressure that we can create on the dialysate compartment in controlling filtration. We call it ultrafiltration if the filter is not that very much porous. So we call it ultrafiltration. And as the filters are developing and become more and more efficient and more fluxing to the volume, we should make sure that this ultrafiltration is accurate. Otherwise, if the ultrafiltration is more than what is needed, the body will be depleted of volume and the patient will pass into hypovolemia, hypotension, and might have shock on dialysis. So we have to measure that, and we have to control that by volumetric control system or ultrafiltration controller. Ultrafiltration controller is adjusted by computer processing and controls two pumps that get the dialysate in and pumps that get the dialysate out. And by the difference between the two pumps can create appropriate flow out of ultrafiltration, and we measure it and is adjusted to do that. And now we end up by this final composition that I told you before, after mixing and monitoring, and this allows everything to go in the right position. So we can make use of some dialysate properties to prevent an important side effect or complication of dialysis, that is hypotension. How do we prevent hypotension by controlling dialysate? We can do that by using appropriate dialysate osmolality, not hypoosmolar. And we can lower dialysate temperature. This makes the body a bit sympathetic over delivering some vasoconstriction and cause elevation of the blood pressure. We use some sort of higher calcium dialysate, but this has got some drawbacks that I will talk about. And we reduce the concentration of acetate because many patients are intolerant to acetate, so that they become hypotensive when they are exposed to high concentration of acetate. In the past, we used to use acetate containing dialysate, but now we are shifting more and more to bicarbonate dialysate. So as most, or I can say all of the units now in Egypt are utilizing bicarbonate dialysate. But some centers advocate citrate containing dialysate. This has got some benefits like anticoagulation, more biocompatibility, and easy to conserve. Now let us talk about sodium concentration in the dialysate. We can use isotonic sodium in the dialysate. This is to say the dialysate sodium concentration equals more or less to that of the patient's serum before dialysis. This dialysate sodium activity corresponds to plasma water sodium activity multiplied 0.7, which is donor factor, and there is no, if there is no ultrafiltration, there is net intra-hemodialysis sodium removal 0. So no sodium gets in and no sodium gets out. So you conserve the sodium concentration as it is, and there is no movement of sodium, provided that there is no ultrafiltration. But if there is some ultrafiltration, some sodium can get out by ultrafiltration. So this might sound okay, but the problem, it doesn't get rid of the extra sodium that accumulates in the patient between dialysis sessions. So the patient might remain hypervolemic. So they started to use the hypotonic dialysate. Here, the dialysate sodium concentration is lower than the plasma sodium concentration at the start before the session. So theoretically, it can be used if the patient should lose sodium by diffusion. So sodium will now diffuse from the blood to dialysate because the concentration in the dialysate is low. This will lead to decreased plasma osmolality, and this will lead to two possible effects. Number one, if the plasma osmolality gets low, then the cell will imbibe water from the ECF, from the extracellular space, and the cell will swell. There will be cellular overhydration, cell swelling. And the important cell that suffers from that is the brain cell. So the patient passes into headache, vomiting, and disequilibrium. The other problem of hypotonic dialysate is the water will go to the cell and the plasma water will decrease, the ECF water will decrease, and the patient will pass into resistant hypertension. This is the important effect of low sodium dialysate. Yes, it helps removal of BUN more, because BUN will go out of the cell by water getting inside and BUN getting outside. And it helps water removal from the patient, but it will cause hypotension in many cases. The third type of dialysate sodium concentration is hypernatremic dialysate or hypertonic dialysate. So now it might be more tempting to use it to cause more ultrafiltration without hypotension, because now we can deliver sodium to the patient and have more loss of water from the cell. So we can do more ultrafiltration without hypotension. But the problem is it will cause insufficient net sodium removal, because sodium will diffuse with the patient, and this might cause refractory hypertension. And the patient will suffer from thirst because of hyperosmolality. So he drinks a lot. And it comes with a lot of gaining of weight, a lot of weight gain between dialysis. So during the session, the treating physician will exercise more ultrafiltration and more stress on dialysis, and he might favor hypotension. But day by day, using high sodium concentration dialysate will cause sodium overload, heart failure, and pulmonary edema. So none of them is ideal. So to be physiological, the sodium mass balance must be zero, meaning that the sodium that the patient gains during the interdialytic period should be get rid of during dialysis. A zero sodium balance between the intra-hemodialysis sodium removal and the inter-hemodialysis sodium accumulation can be achieved by individualizing the dialysate sodium concentration for each dialysis. but this is quite difficult actually, because you have to measure it, monitor it, and know how much do you add and how much do you remove. So it's not that feasible in mass treatment of many patients. This summarizes what happens if you use low sodium dialysate and high sodium dialysate. Now, during the 90s and the early 2000s, some physicians start to play around by the conductivity kinetic modeling, which is modifying sodium concentration or conductivity of the dialysate on each phase of dialysis. This might be linear, exponential, or step pattern. When you start with high sodium concentration and you go down to normal or even low sodium concentration by the end. So this might help some patient actually, but it is not agreed upon by all authorities. This is the three methods. The stepwise, which is a dotted one, the linear, and the exponential. When you start with high sodium concentration like that, and you decrease the sodium concentration by time, so as you end your dialysis treatment, the sodium concentration near normal or even below normal. So in some but not all studies, sodium modeling has been shown to be effective in treating intradialytic hypertension. Some advocate indications and contraindications for this sodium modeling. Indications like intradialytic hypertension, cramping, initiation of hemodialysis in setting of severe azotemia, and hemodynamic instability. But some contraindications like intradialytic development of hypertension and large intradialytic weight gain induced by high sodium dialysate and hypernatremia. So these are obstacles to do dialysis, carry out dialysis with the sodium kinetic. Now we will talk briefly on dialysate sodium. Actually, sodium usually accumulates in the patient and we need to remove it during dialysis. But the problem is that most of the potassium is inside the cell. So you can deplete the serum potassium easily during dialysis, but this doesn't constitute the major burden of the patient. The major burden is inside the cell. And the rate of extrusion of potassium from the cell to the extracellular fluid is a lot slower than the rate of removal by potassium from the blood and ECF to the dialysate. So this means that after dialysis, the potassium will return back again high due to diffusion of potassium from the cell to outside. Some factors might pertain or obviate the removal of potassium from the body, like anything that helps potassium to go inside the cell. Glucose-containing dialysate stimulate potassium to go inside the cell. And during dialysis, we correct acidosis by using bicarbonate, and it also helps potassium to be hidden inside the cell. And if you use beta stimulant before dialysis session, it also prevents potassium from getting out of the cell. So if you are aware of that, you can make use of some phenomena to increase potassium efflux from the cell and help removal of potassium. Briefly about dialysate calcium. Dialysate calcium concentration is between 1.25 to 1.75 millimole per liter. If you want to make it milliequivalent, you times that by 2. And this will cause a negative or positive intradialytic calcium value. So you either lose calcium or gain calcium during dialysis. The high concentration might be helpful to exercise hemodynamic stability and helps patients with cardiovascular compromise. But the problem is it increases the burden of calcium in the body, so it helps hypercalcemia, it helps calcification of the vascular and extraosseous tissue. This is quite hazardous and causes cardiovascular mortality. Especially if the patient is using calcium salts as phosphate binder, it is often advised to use low calcium dialysate to prevent hypercalcemia. But this can cause hypotension during dialysis. So you have to find the appropriate thing for each patient. Now, buffers of the dialysis. Usually we used to use acetate buffers, but some patients might not be able to tolerate that. This is the composition of the acetate buffer that is present here. Sodium 138, potassium 1.5, calcium 2.5 milliequivalent, magnesium 1.5 milliequivalent, chloride 107, and acetate 36.6. So all the buffer is acetate. Acetate in the body will become bicarbonate during the metabolism, utilizing the fifth cycle. But the problem is the rate of conversion of acetate to bicarbonate is not the same in each patient, and some patients are slower. So acetate accumulates in the blood, causing acidosis and acetic intolerance with vomiting, headache, and a lot of medication. Bicarbonate is a lot helpful. So using bicarbonate as a buffer is associated with less dialysis-induced morbidity and vascular instability. So we can make use of this bicarbonate. And now all the patients are using the bicarbonate. So bicarbonate now is becoming the standard buffer. And we are looking forward for newer buffers that's more biocompatible. This is the composition of the bicarbonate solution. Usually we have to, the carbonate comes in a powder and the concentrate, the other solute concentrate come in acidic container. You cannot mix them before dialysis because it will form stone. So you have to mix them just inside the machine. And this is the bicarbonate powder. And this constitutes what I want to deliver the message in the 30 minutes of my lecture about dialysis. Thank you.
Thank you, Professor Nagy, for your excellent talk. Now open for discussion. Dr. Nagy, one point regarding if you are facing patients with hyperkalemia before dialysis. Hyperkalemia. Do you prefer to give the measures of hyperkalemia before dialysis?
To get
to control, yes, measures like sodium bicarb, like